everybody, welcome to this session. In this session, we are going to discuss previous year questions from NEET PG 2022. Shall we start? Let's start with the first question. Identify the type of cartilage. Cartilage as such is a very high-yield topic. Frequently, we get questions from this in your competitive examination. So, yes, before answering it, let's move on to a brief discussion. What do you think are the components that make up the cartilage? The cells of the cartilage, they are called the chondrocytes. And these chondrocytes are located in a cavity within the matrix. It's called chondrocytes in lacunae, right? And then the extracellular matrix, that is made up of the fibrous component and the ground substance. What are the fibers you know? Collagen fiber, elastic fiber, reticular fiber, isn't it? Reticular fibers, you know, they form the supportive framework of the lymphatic tissue, right? And the ground substance, it consists of glycosaminoglycans, proteoglycans, and so on. So these are the components that make up the cartilage. What is the outermost covering of the cartilage called? Periosteum. What are the three types of cartilage you know? Hyaline cartilage, elastic cartilage, and fibrocartilage. Come on, let us look into it. The hyaline cartilage, it has a perichondrium, and as I told you, the perichondrium is the outermost layer of the cartilage, isn't it? This perichondrium, it consists of two layers. An outer fibrous layer made up of collagen fibers and inner cellular layer. The fibrous layer of the perichondrium is made up of type 1 collagen fiber, right? And coming to the matrix as such. So here we get to see collagen fibers, but the collagen fibrils, they have the same refractive index as that of the ground substance. So you will not be able to see any fibers within the matrix. Hence, we call it as homogeneous matrix. This term is very exclusive of hyaline cartilage. The term hyalose, it means glass-like, a transparent matrix, because the collagen fibrils, they have the same refractive index as that of the, yes, the ground substance in the matrix, right? And then another feature very exclusive of hyaline cartilages about the matrix is, can you see? It is bluish. We call it as intensely basophilic matrix. Why so? Because the chondrocytes, they are surrounded by the newly formed matrix, which is rich in proteoglycans. That gives it a bluish hue, right? So we call it as intensely basophilic homogeneous matrix, very characteristic of hyaline cartilage. Coming to the cellular component, that is also interesting. Can you appreciate? The cells are not singly placed, but they are arranged as groups, and we call them as isogenous cell nest. The daughter cells, which are derived from the parent cell by mitosis, they remain close to the parent cell, and this is called as isogenous cell nest. Very characteristic of hyaline cartilage. So each isogenous cell nest, it may contain as much as 3 to or like 4 to 8 cells in a hyaline cartilage. The elastic cartilage also, we have isogenous cell nests, but they have smaller cell numbers, right? Like 2 to 4, okay? And the matrix, the collagen fibrils, I told you they have the same refractive index and it appears transparent. The fibers present there, they are made up of type 2 collagen, right? So come on, let's summarize the features of hyaline cartilage. It has a perichondrium, the cells are arranged in isogenous cell nest, and what type of matrix we have? Intensely basophilic homogeneous matrix, right? The matrix that immediately surrounds one newly formed cell. It's called capsular matrix. And the matrix that surrounds the isogenous cell group, it is called territorial matrix. Okay, that is less basophilic. And then between the isogenous cell nest, okay, it is going to be less basophilic. That is called interterritorial matrix. Coming to elastic cartilage, why do you think it's called elastic cartilage? Because the matrix contains more amount of elastic fibers, right? The elastic fibers present here, they are more numerous, they are thick, dense, and show branching pattern, right? Very, very characteristic of elastic cartilage. And as you see here, the perichondrium is present. The matrix will have type 2 collagen fibers. And again, the cells that you see here arranged as isogenous cell nest, but just fewer number, 2 to 4. Okay, so the characteristic features of elastic cartilage, let us summarize. It has a perichondrium. The perichondrium of hyaline and elastic cartilage made up of type 1 collagen fiber. The cells are isogenous cell nest 2 to 4, and in the matrix we have abundant elastic fibers, thick, dense, numerous branching. The matrix has type 2 collagen fibers. Okay, so here this is a special stain to show the presence of elastic fibers in the matrix of the elastic cartilage. Fine, and you can see these are the chondrocytes in lacunae. Coming to fibrocartilage, the very characteristic that you should appreciate is the absence of perichondrium. So, it doesn't have a perichondrium. You can see bundles of collagen fibers running in different directions, arranged parallel to the direction of stress. Okay, and these collagen fibers close to it, you can see the fibroblast nuclei. Apart from that, you can also observe chondrocytes in lacuna, right? And the ground substance is very minimal. The collagen fibers that you see here in the matrix is made up of type 1 in contrast to elastic and hyaline cartilage. No perichondrium, chondrocytes in lacuna, right? And bundles of collagen fibers. Matrix has type 1 collagen fiber. Now, time for you to identify. So, this is a high yield topic. Definitely you'll get questions from it, but it's not the same image repeating every time, isn't it? Come on, help me to identify. A is abundant eosinophilic elastic fibers in the matrix. Yes, correct. It is the elastic cartilage. And B here, what do you appreciate of the matrix? It is basophilic, bluish, and homogeneous. You don't get to see any collagen fibers there, right? This is going to be the hyaline cartilage. Right? You can see the perichondrium here, right? The perichondrium. And what is C here? You can see chondrocytes in lacuna, right? And the bundles of collagen fibers. And no perichondrium, fibrocartilage. Right? One more. Yes. One is fibrocartilage. Did you guess it right? Abundant collagen fibers, right? Can you appreciate the chondrocytes in lacuna? And 2 is, yes, You can see the eosinophilic collagen fibers in the matrix, right? Elastic cartilage. And 3, yes, it's not that very basophilic. Still, you can appreciate the presence of perichondrium in elastic cartilage and hyaline cartilage. Here, the isogenous cell nest you can make out, and a homogeneous matrix, isn't it? This is going to be hyaline cartilage. The articular surfaces of the bones contributing to the joint, right? They are covered by hyaline cartilage and they are called articular cartilage. But this articular cartilage that covers the articulating surface is devoid of perichondrium. Okay? The perichondrium has a rich blood supply, nerve supply, lymphatics. But within the cartilage, there is no blood vessels, no nerves, no lymphatics. What are the areas where you find these cartilage types? Okay, hyaline cartilage, the best example is the epiphyseal growth plate, right? And then, can you put your fingers over the trachea and feel? That's also made up of hyaline cartilage. Right? Hyaline cartilage is more rigid, strong, isn't it? It can calcify and ossify also. Again, the cartilages of the larynx, the thyroid cartilage, the cricoid cartilage is made up of hyaline cartilage. And can you identify what is this cartilage of the larynx? Arytenoid. Most of the arytenoid is made up of hyaline cartilage. You can see the ribs here, the sternum here. Yes, what is this? Connecting the sternum to the ribs, the costal cartilage. That is also made up of hyaline cartilage. Okay, so the epiphyseal growth plate, the trachea, the cartilages of the larynx, thyroid, cricoid, most of the arytenoid, and the costal cartilage are the best examples for hyaline cartilage. What about elastic cartilage? Remember 3 E's. What are they? So, the eustachian tube that you see here, connecting the middle ear cavity to the nasopharynx, right? And then the pinna of the ear, external ear. This cartilage here is the epiglottis, right? So the elastic cartilage is found over the eustachian tube, the epiglottis and the pinna of the ear. Apart from that, yes, I told you most of the arytenoid is made up of hyaline cartilage. The apex and the ocal process of the arytenoid are made up of elastic cartilage. Okay, and then the top of the arytenoid, it articulates with 2 small cartilages, do you remember, found within the aryepiglottic fold. What are they? The corniculate and cuneiform. They are also made up of elastic cartilage, right? So apart from the 3 E's, do remember the apex of the arytenoid and the ocal process of the arytenoid, and corniculate and cuneiform. What is the feature of the elastic cartilage? Flexibility, right? The ocal process will give attachment to the ocal cord. It has to be flexible throughout the life, right? So it cannot like ossify or calcify. Fibrocartilage, what are the sites in the body where you get to see the fibrocartilage? The fibrocartilage is strong as that of the hyaline cartilage, flexible as that of the elastic cartilage, but this doesn't calcify or ossify. So what is this in related to your hip joint? Yes, the acetabular labrum. It is made up of fibrocartilage, and in relation to the shoulder joint, the glenoid labrum. Here you can see the menisci of the knee joint made up of fibrocartilage. Also, the articular disc of temporomandibular joint is made up of elastic cartilage. These are the menisci of the tibia. And the best example, the intervertebral disc that lie between the bodies of the vertebra, made up of fibrocartilage. So, what is the type of cartilage shown here? You don't get to see a perichondrium, and you can see, yes, lot of cells there, chondrocytes in lacuna, and in between the pink there is the collagen fiber bundle. Because of absence of perichondrium and the collagen fiber bundle, we are going to call it as the fibrocartilage. Fine. So, articular cartilage is a type of hyaline cartilage without the perichondrium. Non-articular cartilage is same as that of the rest of the hyaline cartilage. Elastic cartilage and fibrocartilage. So, the answer is fibrocartilage. So, in this question, we have discussed in detail about the 3 cartilage types. Okay. And the histological images related to it. We have seen more than 3 types of histological image for each type of cartilage, isn't it? Okay. Now moving on to the second question. Which of the following is most likely seen due to rupture of saccular aneurysm in the brain? Do you know what's the other name for the saccular aneurysm? The berry aneurysm that involves the circle of Willis. And rupture of this berry aneurysm, it produces subarachnoid hemorrhage. Shall we have a quick discussion over this high yield topic? So, what is this picture that you see here? The base of the brain, isn't it? Right? What are the arteries you get to see here? This one here is the vertebral artery. Right? The right and the left vertebral artery, they unite to form the basilar artery that lies over the ventral surface of the pons. And what does this basilar artery terminate into? The posterior cerebral arteries. Can you see it over here? This one here is the posterior cerebral artery. And this is the terminal part of internal carotid artery. The terminal part of the internal carotid artery is going to give rise to 2 terminal branches. This one that you see here arising from the internal carotid and going anteriorly is the smaller terminal branch of internal carotid. We call it as the anterior cerebral artery. Right? This one here is a larger terminal branch of the internal carotid artery, the middle cerebral artery. This one here is the anterior choroidal artery coming from the internal carotid artery. And this branch you can see joining the posterior cerebral artery. This is the posterior communicating artery. So these are the branches of internal carotid over here. The anterior cerebral, middle cerebral, anterior choroidal and the posterior communicating. So the question was about saccular aneurysm, berry aneurysm, right? And I told you it involves the circle of Willis. Where is this circle of Willis? Over here in the base of the brain, right? In the interpeduncular fossa. And in the subarachnoid space of the interpeduncular fossa called the interpeduncular cistern, where you get to see all these branches right? So let us see what are the arteries contributing to circle of Willis, right? It's a very high yield topic. Once they ask which of the following artery is not contributing to circle of Willis, that's why. So here, this is the terminal part of the internal carotid artery, which contributes to the circle of Willis on the lateral aspect. And yes, coming from the internal carotid, this is the anterior cerebral artery. So the anterior cerebral artery, and then the anterior cerebral artery of both the sides, they are connected by this anterior communicating artery, right? Similarly here, we have the posterior communicating artery, again a branch of the internal carotid artery. And over here, the posterior cerebral artery, which is the terminal branch of the basilar artery, the proximal part of the basilar artery. All this contributes to the circle of Willis. So which branch of internal carotid is not contributing to circle of Willis? I'll show it in black color. The middle cerebral artery. And here, this was the anterior choroidal artery, right? They do not contribute to the circle of Willis. Fine. So, an aneurysm involving the arteries contributing to the circle of Willis, right? This congenital aneurysm, it's called as the Berry aneurysm. Most commonly involving the anterior communicating artery. So, when the intracranial pressure increases, it can rupture. And where are all these blood vessels situated? The circle of Willis is situated in the subarachnoid space. So, that will lead to subarachnoid hemorrhage. Understood? Fine. So this is an image showing you blood in the interpeduncular cistern in case of subarachnoid hemorrhage due to rupture of a saccular aneurysm or the Berry aneurysm of circle of Willis. This is the superior sagittal sinus. Can you tell me what are these veins draining into the superior sagittal sinus? The cerebral veins. They are also called bridging veins. And in hypertensive patients, when the BP shoots up, when the intracranial pressure increases, these veins, they can rupture, leading to subdural hemorrhage. So, where does the blood accumulate in the subdural hemorrhage? In the subdural space that lies below the dura mater, between the dura mater above and the arachnoid below. In this image, can you identify the dura mater, the outermost thick fibrous layer? And you get to see a hematoma here. This is the subdural hematoma, right? Due to rupture of the bridging veins or the cerebral veins. So this is again a very frequently asked question. Extradural hemorrhage, epidural hemorrhage and subdural hemorrhage in the image given here, right? So here, this is the extradural hemorrhage. And where do you see it's located? I have to redraw this. 1 second, I'll do this slide again. It's in bits and pieces. So this again is a very frequently asked question in your competitive examination, extradural hemorrhage and subdural hemorrhage, right? So this is the extradural hemorrhage. Where is it located? I would like to show you the dura mater in this picture, right? So this one which I am drawing in green color, this is the dura mater, right? And you can see here in the extradural hemorrhage, the blood lies outside the dura mater. The dura gets stripped from the inner surface of the skull. What are the two layers of the dura mater? The meningeal layer and endosteal layer, right? There is no epidural space in the cranial cavity. We have epidural space outside the dura mater only in the vertebral canal. Remember? Okay. So what has happened here? The collection of the blood has stripped the dura from the inner surface of the skull. And what is the shape of the hematoma here? It is biconvex lens shaped, right? The location is, it lies outside the dura mater, right? And rupture of which vessel causes this extradural hemorrhage? Any idea? It's the middle meningeal artery, right? The rupture of the middle meningeal artery related to the pterion. Yes, so it's going to be an arterial bleed in case of extradural hemorrhage. What about subdural hemorrhage? So this is the subdural hemorrhage you see here. It lies inner to the dura mater, where again in the subdural space between the dura mater and the arachnoid, right? And the shape of the hematoma that you see here, it is long and crescentic. So this is the hematoma that you see here in the subdural hemorrhage. Yes, beneath the dura mater. And yes, just now we saw, right, the vessel involved here is the cerebral veins or the bridging veins. Hence, it is going to be a venous bleed. Okay, in both the conditions, because of the enlarging size of the hematoma and the parenchyma getting compressed, the patient will present with symptoms related to raised intracranial tension. It can manifest as headache, vomiting, the cognition can be impaired, and yes, the patient can move on to unconsciousness or coma. So what is the cause for extradural hemorrhage causing rupture of the middle meningeal artery? We know it is related to the pterion, right? And the pterion is situated over the lateral aspect of the skull. So any trauma to the lateral aspect of the skull can rupture the middle meningeal vessels, the middle meningeal artery, right? And the symptoms, just now I told, right, it can manifest from headache and then, yes, vomiting and signs of other intracranial tension. Yeah, unconsciousness on all that. But here in extradural hemorrhage, the patient, he remains non-symptomatic. He looks normal for some time and then goes to unconsciousness. This period is described as lucid interval. Whereas in subdural hemorrhage, it could be due to a fall, a road traffic accident, right? And very common in elderly, epileptic patients, and alcoholics, right? So here again, there can be altered cognition. So you should be definitely able to identify whether it's extradural hemorrhage or subdural hemorrhage just by looking into the picture. Okay, and yes, what are the types of hemorrhage? So we have seen so far. One is the subarachnoid hemorrhage due to rupture of the berry aneurysm. And then just now we saw extradural hemorrhage, that is due to rupture of the middle meningeal vessels, right? And subdural hemorrhage due to rupture of the cerebral veins. Fine. So which of the following is most likely seen due to rupture of sacral aneurysm in the brain? Subarachnoid hemorrhage. So in this question, we have discussed branches of the internal carotid artery. We identified it in the image, and then we saw both circle of Ellis, which arteries contribute and which do not contribute, right? And the types of hemorrhage, intracranial hemorrhage, right? A patient presented with unilateral retroorbital headache, photophobia, excessive tears. He also complains of hemifacial pain on clenching of teeth. On examination, pupillary reaction is normal, light reflex, accommodation reflexes are normal. Which of the following structure is affected? So they have actually given an image-based question to identify A, B, C, D and then answer from it. Okay, so A here is the optic nerve. What is the function of optic nerve? Vision, isn't it? Okay, but nowhere symptoms related to visual defect or visual loss is given. So we'll just leave off optic nerve. Coming to oculomotor nerve, they've told that the light reflex, accommodation reflex, pupillary reaction is all normal. So oculomotor nerve is also normal. And then let's see facial nerve. Please remember, right? In this patient, the symptoms are related to sensory disturbance or paralysis of muscles. Yeah, it's exclusively talking about sensory disturbance, right? Yeah, and this facial nerve, it doesn't have any cutaneous branch. It supplies the muscle of the face but not the skin of the face. So we can just exclude facial nerve also. So the best option is going to be trigeminal nerve. But you should be able to identify it in the image, right? Come on, let us identify it. A here is the optic nerve. And this one, B here, is the third nerve, the oculomotor nerve, right? And this one, C here, is the thickest of all the cranial nerves, which you couldn't make a mistake, the trigeminal nerve. And this one here is the internal acoustic meatus. And D here is the facial nerve. So if you are not happy with this image, let's move on to another image. Come on, where you will be able to identify it with much more clarity. So this here is the optic canal, and the nerve that you see here is the optic nerve, the second cranial nerve. This here is the oculomotor nerve, right? And this one here is the thinnest of all the nerves. Not only that, this is the only cranial nerve that exits from the dorsal surface of the brainstem. The fourth cranial nerve, trochlear nerve. And as I told you, this one you can never make a mistake. The thickest of all the cranial nerves, the fifth nerve, trigeminal nerve, right? And here again, this one here is the sixth nerve, abducent nerve, the internal acoustic meatus transmitting the seventh, and this one, the vestibulocochlear nerve. This is the jugular foramen. Traversing the jugular foramen is the ninth cranial nerve, glossopharyngeal nerve, the vagus, the 10th cranial nerve, and the accessory nerve. What are the two components of the accessory nerve? Cranial and spinal. This root, can you see here, coming through the foramen magnum and joining some nerve in the jugular foramen, is the spinal accessory nerve, right? And over here, these are the rootlets of the 12th nerve, the hypoglossal nerve in the hypoglossal canal, right? So this is a very, very important high yield image showing the cranial nerve exit in the cranial cavity. Okay, so definitely you should be able to identify, because no one is going to ask you for an identification. The question is going to be related to the identified structure. Okay, so make sure you're thorough with the identification of these cranial nerves, right? So now let's move on to the trigeminal nerve. What are the three divisions of the trigeminal nerve? The ophthalmic nerve, the maxillary nerve, and the mandibular nerve. And we know that the trigeminal nerve is a mixed nerve. Most of it is going to be sensory. Yes? Yeah. And few fibers of it, it's going to be motor. That is why we call it as the mixed nerve. The ophthalmic nerve is entirely sensory. The maxillary division is also entirely sensory. The mandibular division is sensory, as well as it carries the motor fibers of the trigeminal nerve. Okay, and the nuclei related to the trigeminal nerve, the sensory nucleus, they are 3 in number in the brainstem. The first one is the spinal nucleus of the trigeminal nerve that receives pain and temperature from face. And then we have the chief sensory nucleus of the trigeminal nerve that receives the touch sensation from face. And then again, we have the mesencephalic nucleus of the trigeminal nerve, which receives the proprioceptive information from the muscles of mastication and the muscles that move the eyeball. Okay, if you need more details, you can have a look into the head and neck cranial nerves, right, on that session. So, plus the motor nucleus of the trigeminal nerve. So, totally 3 sensory nucleus and 1 motor nucleus. The motor nucleus is going to supply the 4 muscles of mastication, masseter, temporalis, medial pterygoid, lateral pterygoid, and 2 tensors, tensa tympani, tensa veli palatini, and 2 more, the anterior belly of digastric as well as the mylohyoid. And remember, the mandibular nerve is the nerve of the first pharyngeal arch, special visceral efferent column. Yes, we have discussed in detail in head and neck session, right? So, for further basic details, refer to head and neck session of the same, right? So, the case scenario given, it describes the patient having sensory disturbance over the upper and the mid part of the face corresponding to ophthalmic division and maxillary division of the trigeminal nerve. So definitely we should learn the name of the branches of these divisions. The area shown here in green color, that is the skin of the face supplied by ophthalmic division of trigeminal nerve. So this one here is the lacrimal nerve. Just medial to it, this is the supraorbital nerve. And this one more medial is the supratrochlear nerve, right? And this one below is the infratrochlear nerve. This one here is the external nasal nerve. Follow, okay? I have a lot of questions at the end of it. So these are all branches of the ophthalmic division of trigeminal nerve, right? Now, here, this one supplying the skin over the lower eyelid and the upper part of the cheek is the infraorbital nerve. This infraorbital nerve is the main continuation of maxillary nerve, right? And this one over here is the zygomaticofacial nerve, and this here is the zygomaticotemporal nerve. All these are branches of maxillary division of the trigeminal nerve, right? Now, this nerve that supplies the skin of the lower lip and the skin of the chin, it is the mental nerve, right? And this one here, yes, that is going to be the buccal branch. And just above, this is the auriculotemporal nerve. And all these are branches of mandibular division of trigeminal nerve. Now, ready for my questions? Come on quickly, looking into the image. Can you tell me, what is the nerve supply of tip of nose? Yes, it's ophthalmic division of the trigeminal nerve. Upper eyelid, ophthalmic division of trigeminal nerve. Lower eyelid, the sides of the nose and upper cheek, maxillary division of trigeminal nerve. Upper lip, maxillary division of trigeminal nerve. What about the lower lip and chin, right? The lower part of cheek, mandibular division of trigeminal nerve, skin over the parotid, great auricular nerve, okay, from the cervical plexus. Now, the ophthalmic division of the trigeminal nerve, it has three branches: lacrimal nerve, the one that you see here, and then frontal nerve. The frontal nerve will divide into two, the one just now we saw, right? Supraorbital and supratrochlear, right? And the third one which you see here is the main continuation, right? It is the nasociliary nerve, right? The nasociliary nerve will give rise to posterior ethmoidal nerve that you see here, the anterior ethmoidal nerve. The posterior ethmoidal nerve will supply the sphenoidal sinus and the posterior ethmoidal sinus. The anterior ethmoidal nerve will supply the middle ethmoidal and the anterior ethmoidal. It will enter the nasal cavity and then it will emerge as the external nasal nerve. Also branches from the nasociliary nerve. You can see it supplying the eyeball, right? This is the ciliary ganglia in the orbit. The sensory fibers through the nasociliary nerve, right? They pass through the ciliary ganglia. So on the whole, you can tell me the ophthalmic division of the trigeminal nerve, it carries the sensation from the eyeball, okay? And also the skin over the upper part of the face. And through the nasociliary nerve, the nasal cavity also, and the ethmoidal and sphenoidal sinuses, right? The lacrimal nerve innervates the lacrimal gland. Okay, it receives the fibers through the zygomatico-temporal branch of maxillary nerve and the skin of the lateral part of upper eyelid. The lacrimal nerve and the frontal nerve, you know how do they enter the orbit? Through the lateral compartment of superior orbital fissure. And the nasociliary nerve, it passes through the intermediate compartment of superior orbital fissure, right? So, where is the maxillary nerve here? This is the maxillary nerve. And you can see a foramen here. The maxillary nerve, it passes through the foramen rotundum. And it reaches this area that you see here, which is called the pterygopalatine fossa. And in the pterygopalatine fossa, can you see here there's one ganglia, the pterygopalatine ganglia, right? So this maxillary nerve through the ganglionic branches, it will communicate with the pterygopalatine ganglia. The main continuation of this maxillary nerve will enter the orbit as the infraorbital nerve. The branches of the maxillary nerve will of course supply the maxillary sinus, the upper jaw, and we saw, right, the skin over the mid part of the face, right? So yes, any involvement of this nerve can lead to pain over the territory supplied by it. And lastly, the mandibular division of the trigeminal nerve. Remember, this is important. The ophthalmic and the maxillary division of trigeminal nerve are entirely sensory, but this is a mixed nerve. It has the motor component also here. So this is the mandibular division of the trigeminal nerve. I would like to point out the mandibular nerve. This is the mandibular division of the trigeminal nerve. You can see it passing through a foramen. Yes, that foramen here that you see is the foramen ovale. The mandibular nerve, it exits the middle cranial fossa through the foramen ovale and reaches this area called the infratemporal fossa, right? And in the infratemporal fossa here, it's going to be related to a ganglia called the otic ganglia, right? And what are the branches coming from this mandibular nerve? it has a trunk. The trunk will then quickly divide into a anterior division and posterior division. Branches coming from the trunk will include nervus spinosum and nerve to medial pterygoid. This nerve to medial pterygoid will pass through the optic ganglia without any synapsing and will go ahead to supply, of course, the medial pterygoid, but also the two tensors, tensor tympani and tensor palatini. Tensor tympani, where do you get to see it? Within the middle ear, right? And tensor veli palatini is a muscle of the soft palate, right? So here you can see the trunk of the mandibular nerve. This nerve, right, is the nervus spinosum. The nervus spinosum and the middle meningeal artery, it passes through the foramen spinosum, right? Now, let us see the branches coming from the anterior division of the mandibular nerve. They supply the muscles of mastication. So, the masseteric nerve that supplies masseter muscle, the deep temporal nerves that supply the temporalis muscle, the nerve to lateral pterygoid. The nerve to medial pterygoid also, the nerve to medial pterygoid also comes from mandibular nerve, but from which part of the mandibular nerve? From the trunk, isn't it? And one more nerve, very important, the buccal branch of mandibular nerve. Any guess why am I showing it in red color? Please remember, these three are motor. The buccal branch of mandibular nerve is sensory. Why it should be highlighted? There is a muscle over the cheek called buccinator, right? This is your buccinator muscle. And this buccinator muscle is going to be supplied by buccal branch of facial nerve, the lower buccal branch of facial nerve. So you shouldn't confuse this buccal branch of facial nerve, that is motor, with this buccal branch of mandibular nerve. First point. Another thing is that this buccal branch of mandibular nerve, it pierces the buccinator muscle to supply the skin of the cheek, right? So this is again a confusing point. The buccal branch of mandibular nerve will pierce the buccinator but doesn't supply it because it's not a motor nerve. It supplies the overlying cheek, the skin of the cheek. Understood? So 4 branches from the anterior division, 3 motor and 1 sensory. Now let us move on to the branches coming from the posterior division of the trigeminal nerve. Very, very, very important, right? Now let us see the branches coming from the posterior division. There are 3 branches coming from the posterior division and it is important to know them here, right? The first one is this one, the inferior alveolar nerve. You know why it is called inferior alveolar nerve? It is going to supply the teeth of the lower jaw, all the teeth of the lower jaw, the molar, the premolar, the canine and the incisor, right? And there was one question in the competitive examination pointing to a foramen on the inner surface of the mandible asking what passes through it. Okay, so that is the inferior alveolar nerve passing through the mandibular foramen, right? So you can mistake it for mandibular nerve entering the mandibular foramen. It's not so. The mandibular foramen is passing through the, the mandibular nerve is passing through the foramen ovale. The structure passing through the mandibular foramen on the inner surface of the mandible is this inferior alveolar nerve. But before it enters that mandibular foramen, it will give this branch. It is called as nerve to mylohyoid. This is the mylohyoid muscle. So this nerve to mylohyoid will of course supply the mylohyoid. In addition, it supplies the anterior belly of digastric. The posterior belly is supplied by the facial nerve. Okay, so that's about the inferior alveolar nerve. Moving on, totally I told you there are 3 branches, right? Moving on to the second branch coming from the posterior division. This one here is the lingual nerve. As the name suggests, the lingual nerve, it receives the general sensation from the tongue, from the anterior two-thirds of the tongue. Another interesting feature of this lingual nerve is, yes, come on, tell me your chocolate question. Can you see a nerve joining the lingual nerve from behind? Can you tell me what could this be? This one, yes, which is shown in pink color, is the chorda tympani branch of facial nerve, right? This chorda tympani branch of facial nerve, you know what it does? It hands over its fibers. It hands over all the fibers it carries to the lingual nerve at this juncture. It carries the preganglionic parasympathetic fibers for the secretomotor fibers for the submandibular and sublingual salivary gland. Right? So that's about the lingual nerve. And the third one is this branch that you see here, arising as 2 roots and enclosing the middle meningeal artery between its 2 roots. Yes, you're right. It's the auriculotemporal nerve. Right? So, of course, it supplies the temple of the forehead, right, where the graying of the hair starts. It supplies the auricle, but most important, please remember, it carries the postganglionic fibers for the parotid, right? So, if you go to head and neck session, the same topic on mandibular division of trigeminal nerve, we would have talked about Frey's syndrome, isn't it? Yeah, any details you need, please refer to that session. To summarize, the branches coming from the mandibular nerve, from the trunk, nervus spinosus and nerve to medial pterygoid that supplies medial pterygoid, tensor tympani and tensor veli palatini. From the anterior division, yes, the branches to the muscles of mastication other than medial pterygoid, nerve to lateral pterygoid, the deep temporal nerve supplying the temporalis muscle and masseteric nerve, plus 1 sensory branch, the buccal branch. And from the posterior division, 3 nerves, the lingual nerve, inferior alveolar nerve and the auriculotemporal nerve. Of these 3 divisions, which one is motor? The inferior alveolar nerve, right? Okay. So, a patient presented with unilateral retroorbital headache, photophobia, excessive tears, all referring to ophthalmic division of trigeminal nerve, right? And hemifacial pain on clenching of teeth, right? Referring to the other divisions of the trigeminal nerve, pain over the face, we know it's trigeminal nerve. On examination, yes, the oculomotor component was normal. Which one is affected? The structure C. So, in this question, we have seen about, the cranial nerves exit from the cranial cavity, the sensory innervation over the face, the trigeminal nerve, its 3 divisions in detail about the mandibular nerve, and the nerve supply of the muscles of mastication, right? Hope it was useful for you. Yes, and the high yield image, the exit of cranial nerves from the cranial cavity, and the other images also equally important. Fine. We'll move on to the next question. A easier one. Identify the image shown below. Right? It is one of the ear ossicle. How many ear ossicles are there? 3. Malleus, incus and stapes. This one here is the malleus, isn't it? And this is the incus and this is the stapes. So the malleus more like a hammer, incus anvil and the stapes compared to the stirrup. So here, another question that they've asked over the previous years. The joint between malleus and incus, what type of joint is it? Saddle type of synovial joint, right? And this joint between the incus and the stapes, incudoscapedial joint, is an example of ball and socket type of synovial joint, where the head of the stapes, it fits into the lower part of the incus, that, right, the lentiform nodule. And the joint between the incus and the stapes, it is an example of ball and socket type of synovial joint, right? Now let us see few more details related to the three ossicles. So this we know it is the malleus. What are the parts of malleus? It presents a head, a neck. The lateral process of the malleus, it gives attachment to the anterior and posterior malleolar folds. The anterior process of malleus will give attachment to the anterior ligament of malleus, right? The upper part of the handle will receive the insertion of tensor tympani muscle. The handle of the malleus, it lies within the tympanic membrane, right? And the incus, it presents a body, a short process that lodges in the fossa incudus. Okay. The long process, the tip of which it articulates with the head of the stapes to form the ball and socket joint, right? The stapes that you see here, the stapes, it presents a head, a neck, the anterior limb, the posterior limb, and the foot plate, right? The neck of the stapes, it receives the insertion of stapedius muscle. So the image given here is undoubtedly the malleus, right? So here we have seen about the joints between the ossicles, the two muscles within the middle ear, tensor tympani and the stapedius. What is the nerve supply to tensor tympani? Just now we finished, right? The mandibular nerve. And stapedius is from the seventh nerve. Again, the stapedius, which is innervated by the seventh nerve, is a derivative of the second pharyngeal arch. The tensor tympani, which is innervated by the mandibular division of the trigeminal nerve, is a derivative of the first pharyngeal arch. Let us move on to the next question. Neuromuscular blockade monitoring through adductor pollicis. Which of the following nerve is tested? They have just asked you indirectly what is the nerve supply of adductor pollicis. So pollicis, we know it is a muscle of the thumb, muscle getting attached to the thumb, causing adduction of the thumb, right? We might mistake it for median nerve because most of the muscles of the thumb are innervated by median nerve, but of course not. The adductor pollicis is going to be innervated by ulnar nerve. I know most of you would get it right, but the ulnar nerve is such an important topic that we have to definitely discuss, okay? A very high yield topic, yes. And for your competitive examination, there's going to be definitely question from upper limb and it's definitely from one of the nerve injuries. Come on, let's have a brief discussion about the ulnar nerve. Let us point out the ulnar nerve here. You see the artery, right? And here, medial to the artery, this nerve is the ulnar nerve, right? You can see it in the arm, but at the elbow region, you can see it going behind. It is laid behind the medial epicondyle, medial to the artery, okay? So the origin of the ulnar nerve is from which cord of the brachial plexus? Medial cord, with the root value C7, C8 and T1. Why have I put that 7 within the bracket? Because it's borrowed from the median nerve in forearm, right? And the course of the ulnar nerve over the arm, in the region of the elbow, forearm, in relation to flexor retinaculum and in hand. Just now I told you, in the arm you see it medial to the brachial artery, right? The ulnar nerve is not related to the anterior part of the elbow or the cubital fossa because it goes behind the medial epicondyle of humerus. And how does it enter the forearm? By passing between the two heads of flexa carpi ulnaris. It is very easy to identify flexa carpi ulnaris in forearm because that is the medialmost muscle. And the nerve that you see here by lifting the flexa carpi ulnaris is the ulnar nerve. And the artery accompanying it will be the ulnar artery. What is the relation to the flexor retinaculum? This is the flexor retinaculum, right? We know that the median nerve passes beneath the flexor retinaculum. Here is a ulnar nerve. Here is a ulnar nerve. It passes superficial to the flexor retinaculum through the Guyon's canal, right? So we have the ligament bridging the pisiform and hamate. It's called the pisohamate ligament, and the area below it is called the Guyon's canal. Ulnar nerve, it passes superficial to flexor retinaculum through the Guyon's canal and it reaches the hand. In the hand, it's going to divide into a superficial branch and deep branch. The superficial branch of ulnar nerve supplies the subcutaneous muscle here, palmaris brevis. And then it supplies the skin over the medial 1.5 part of the palm, the entire little finger and the medial half of the ring finger, right? Okay. And coming to the muscles innervated by the deep branch, the 3 hypothenar muscles that you see here. So below the thumb is the thenar eminence and below the little finger, this is the hypothenar eminence. 3 muscles make it, right? This muscle, which is on the medial border of the hypothenar eminence, it is the abductor digiti minimi. Digiti minimi refers to the little finger and abductor because it's going to abduct your little finger. And this one, yes, just lateral to it is the flexor digiti minimi. If I separate abductor digiti minimi, flexor digiti minimi and see beneath it, I'll get to see the opponent's digiti minimi. So these 3 are the hypothenar muscles, right? Apart from this, the deep branch of ulnar nerve supplies these 2 muscles. What are they? The 4th and the 3rd lumbricals, right? And then it supplies this muscle going towards the thumb. What is it? Adductor pollicis, the one that the question was framed on, right? Adductor pollicis. Apart from that, interestingly, yes, the ulnar nerve supplies all the interossei in the hand, the palmar interossei and the dorsal interossei, right? Over the forearm, the ulnar nerve supplies 1.5 muscle. What is that 1.5? It supplies flexor carpi ulnaris and the deep muscle of the forearm, the flexor digitorum profundus. The flexor digitorum profundus will have 4 tendons, right? For the index finger, middle finger, ring finger and little finger. The ulnar nerve supplies the flexor digitorum profundus tendon for the little finger and the ring finger. right? So flexa carpi ulnaris will help to flex the wrist as well as ulnar deviation. Flexor digitorum profundus will insert into the distal phalanx of the ring finger and little finger. It will cause flexion of the distal phalanx of those digits, right? The hypothenar muscles, as the name suggests, will cause abduction of the little finger and then flexion of the little finger as well as opponents of the little finger, right? The lumbricals, what is the action of the lumbricals? Yes, I have an image here. These are the lumbricals. You know, this is the first metatarsal, the second metatarsal, the third, the fourth and the fifth. These are the tendons of flexor digitorum profundus. The lumbricals, they originate from the sides of flexor digitorum profundus. How many are there? 4. And how are they numbered? From lateral to medial. The first lumbrical, the second lumbrical, the third and the fourth lumbrical. And you can appreciate that the first and the second are unipinnate. The third and fourth are bipinnate. Isn't it? Right? Where do these lumbricals go for insertion? See? It is not over the palm. The tendon of the lumbricals, can you appreciate? Right? It is passing through the web space and entering the dorsum of the hand. It joins the dorsal digital expansion over the dorsal surface of the digits. Got it? Pass through the web space. Insertion, it joins the dorsal digital expansion, right? The origin and insertion of lumbrical is interesting. It originates from the sides of flexor digitorum profundus tendon. It inserts into the dorsal digital expansion. What will be the action of the lumbrical? So this is your metacarpophalangeal joint. The relation of lumbrical to the metacarpophalangeal joint is it is anterior. It will bend the metacarpophalangeal joint. And since it is inserting into the dorsal digital expansion, dorsal surface of the digits, it causes extension of the interphalangeal joint, the proximal and distal interphalangeal joint. Can I repeat that for you again? Yes, the lumbricals will cause this action, inverted L. Flexion of the metacarpophalangeal joint and extension of the interphalangeal joint. The reversal is clawing, extension of the metacarpophalangeal joint and flexion of the interphalangeal joint, right? So, yes, action over the metacarpophalangeal joint is flexion, over the proximal and distal interphalangeal joint is extension, right? Nerve supply of the lumbrical is again interesting. The first and the second lumbrical is innervated by median nerve. The third and fourth lumbrical is innervated by ulnar nerve. So definitely lumbricals is a very high yield topic. It has been asked in an image-based question, whether first, second, third or fourth. So you should get orientation to its numbering, its location, attachments, nerve supply action, and what will happen in its paralysis is claw hand. Right? So claw hand can happen in both median nerve injury and ulnar nerve injury. In ulnar nerve injury, there will be clawing of the little finger and the ring finger. Right? So this is the palmar interossei. As you see here, the palmar interossei, they are unipinnate muscles. The palmar interossei, the mnemonic is PAD. They cause adduction of the digits, right? Adduction of the digits. So the axis passes through the middle finger. All the fingers moving towards the middle finger is called adduction. Since the middle finger, it lies in the axis, you can appreciate that there is no palmar interossei for the middle finger, right? And this is an image showing you the dorsal interossei. Can you appreciate? So this is your first metacarpal, the second, the third, the fourth and the fifth metacarpal. We can see that the dorsal interossei arise from the adjacent side of the metacarpal bones and all of them are bipinnate, in contrast to palmar interossei which were all unipinnate, right? And all of them are going to be innervated by the deep branch of ulnar nerve, both palmar interossei and dorsal interossei. The dorsal interossei, right, dab, it causes abduction of the digits. So I told you the axis, it passes through the middle finger, right? The middle finger can be moved on either side. So if you appreciate, you can see that the middle finger will receive the insertion of two dorsal interossei to move it on either side, right? So what are the conditions in which the ulnar nerve can get injured, right? So can you appreciate this image? This is the lower end of the humerus. This is the fractured medial epicondyle. We know that ulnar nerve, it runs behind the medial epicondyle. So fracture of medial epicondyle can injure the ulnar nerve, right? And in the region of the elbow joint, right? There's a space between the capsule of the elbow joint and the ulnar collateral ligament. This is called cubital tunnel, where the ulnar nerve can get compressed. And again here, in relation to the flexor retinaculum, we saw that it passes superficial to the flexor retinaculum beneath the pissohamate ligament, right? This is the pissohamate ligament. That region is called Guyon's canal. Again, it can get compressed here. And yes, injury to the lower trunk of brachial plexus, we call it as Klumpke's palsy, remember? Yes, where the ulnar nerve can get injured. Okay, so what are the features of ulnar nerve palsy? We saw that it supplies the hypothenar muscles. So it can present with atrophy of the hypothenar eminence, right, due to paralysis of those muscles. And here, yes, we have seen claw hand involving which digits? The little finger and the ring finger, due to paralysis of third and fourth lumbricals. And again, this is a very high yield topic, yes, based on image, right, as well as MCQs case scenarios. Certain tests very specific to diagnose ulnar nerve injury. The first one here is the card test. So you place a card between the fingers of the patient. You ask him to hold the card tight. At the same time, you try to pull it out. The patient will try to hold the card using adduction of the digits. The adduction of the digits is by palmar interossei innervated by the ulnar nerve. So in ulnar nerve injury, he will not be able to adduct the digits or hold the card. The card might fall loose, right? And here again, okay, so instead of a paper, imagining a book there, you ask the patient to hold a book, right? Hold a book like this. This is called as the book test for ulnar nerve. Do you think it's normal or abnormal? This is the right hand, this is the left hand, isn't it? So here, if the adductor pollicis is intact, he will be able to hold it normally. Do you remember the movements of the thumb? Flexion, extension, adduction, where you bring the thumb, yes, close to the other digits. And this is abduction. So when you try to hold a book, you hold it like this. If the adductor pollicis is intact, as in this patient's left hand, okay, and if the adductor pollicis is paralyzed, he will not be able to hold the book using adductor pollicis, using adduction, but still he will try to hold the book by flexion of the thumb. That is what you see here, the thumb being bent, right? Because the adductor pollicis is paralyzed. This bending of the thumb, it is called Frohman sign. And the muscle paralyzed is the adductor pollicis. This question was on adductor pollicis, right? Yes. And this test, where you ask the patient to move his middle finger on either sides, testing for the dorsal interossei, which causes abduction. This test is called Igawa test, right? Yes, we have to know definitely which part of the hand is innervated by the ulnar nerve, because if you're given a case scenario describing loss of sensation over this part of the hand, you should be able to clinch on the diagnosis, right? The ulnar nerve, it innervates medial 1.5, both over the palmar surface as well as dorsum of the hand. So this area involving the little finger and the medial half of the ring finger on the palm as well as over the dorsum of the hand, innervated by the ulnar nerve, the cutaneous branch, the superficial branch of the ulnar nerve, right? So the neuromuscular blockade monitoring through adductor pollicis, the nerve tested is ulnar nerve. So as I told you, it's a very high yield topic and we have seen 360-degree all about ulnar nerve, right? The concepts we have learned and also a lot of images related to ulnar nerve and ulnar nerve injury. Okay, now let us move on to the next question. Which of the following ligament develop in the arrow mark structure? Right? Let us orient to this image. What you see here is the dorsal aorta, the branches of which seem to supply the developing kidney. So this is the dorsal or the posterior aspect. This is the ventral or the anterior aspect for this image, right? And the second thing, this is the developing gut tube, right? This gut tube is attached to the dorsal body wall by means of dorsal mesentery. And at the same time, it is anchored to the anterior abdominal wall by this ventral mesentery. You see something developing in the dorsal mesentery, right? This is the spleen, and this one developing in the ventral mesentery is the liver. The development of the liver in the ventral mesentery will divide the rest of the ventral mesentery into number of ligaments, as well as the spleen developing in the dorsal mesentery will again divide it into many ligaments. Come on, let's see it. So this is another image of the same concept. Let me see how you are able to identify it, okay? So this is the gut tube, right? And this is the dorsal surface of the gut tube, right? It is going to be anchored to the dorsal body wall by the dorsal mesentery, and at the same time to the anterior abdominal wall by the ventral mesentery. Remember what develops in the ventral mesentery? The liver. And here in the dorsal mesentery, the spleen, right? The ventral mesentery, it is going to persist only in the region of the stomach. Hence, we can even call it as the ventral mesogastrium. With the development of the liver, this part of the ventral mesentery, that lies between the liver and the anterior abdominal wall, it forms the falciform ligament. And this part that lies between the liver and the diaphragm above, that will give rise to the peritoneal ligaments connecting the liver to the diaphragm. What are they? The superior and inferior coronary ligaments of liver, and remember the right and the left triangular ligaments. This part of the ventral mesentery that extends between the liver and the stomach, come on, it forms the lesser omentum. Okay, so these are the derivatives of the ventral mesogastrium, the falciform ligament, the coronary ligament, the triangular ligament, and the lesser omentum. The dorsal mesentery in the region of the developing stomach, we call it as dorsal mesogastrium. The mesenchymal cells in the dorsal mesogastrium, they give rise to the spleen, right? So, this part of the dorsal mesogastrium that extends between the stomach and the diaphragm above, it is called gastrophrenic ligament. The part extending between the stomach and the spleen, gastrosplenic ligament. Right? And the rest of the greater curvature is going to give attachment to greater omentum. We know that the dorsal surface of the gut tube is going to be anchored to the posterior abdominal wall by dorsal mesentery. Okay, so the rest of the dorsal mesentery, we can see that it persists in certain regions. In the region of the small intestine, it will give rise to the mesentery, the peritoneal fold, the broad fan-shaped peritoneal fold that suspends the coils of jejunum ileum, right? And the transverse mesocolon, the mesoappendix. Also, yes, in relation to the spleen, the lieno-renal ligament, the lienophrenic ligament, the phrenicocholic ligament, all these are considered to be remnants of the dorsal mesentery, right? So this is another image, sagittal section, where we are going to identify the derivatives of ventral and dorsal mesentery. Shall we? So this is the liver, the stomach, the transverse colon, the small intestinal loops, and retroperitoneal structures. This is the duodenum and pancreas here. What is shown here in blue color is that part of the peritoneal cavity which lies behind the stomach, the lesser sac. And the rest of the peritoneal cavity that you see here is the greater sac. Now, this ligament extending between the liver and the stomach, can you tell me? What is it? The lesser omentum. And this one, from the greater curvature of the stomach towards the transverse colon, will be the greater omentum. This one anchoring the transverse colon to the posterior abdominal wall, extending to the anterior border of the body of the pancreas, the transverse mesocolon. And this peritoneal fold holding the small intestinal loops, the mesentery. Right? This is a very high yield topic. The derivatives of ventral mesogastrium and the dorsal mesentery are frequently asked. Okay, so please remember the ventral mesogastrium, that will give rise to falciform ligament, the superior and inferior coronary ligament, and the right and left triangular ligament. These are the peritoneal ligaments related to the liver, and the lesser omentum that stretches between the liver and the lesser curvature of the stomach, isn't it? The dorsal mesogastrium, the remnants of it are the gastrophrenic, gastrosplenic, and greater omentum. And the dorsal mesentery will give rise to lenorenal, phrenicocholic, the mesentery, transverse mesocolon, sigmoid mesocolon, and mesoappendix. And please remember, the spleen is not derived from the gut tube. It is derived from the mesenchymal cells in the dorsal mesogastrium, right? So let us see gross anatomy images and identify these ligaments. The question can be framed the other way around, right? The ligament can be pointed out in a gross anatomy specimen and they can ask you what is it a derivative of. So this one here, dividing the liver into right and left lobe, is the falciform ligament. This is the superior coronary ligament. This is the inferior coronary ligament. This one that you see here is the right triangular ligament. The superior coronary ligament, the inferior coronary ligament, and the right triangular ligament, they form the boundaries of bare area of liver, right? For further details on this, please refer to the session in liver, right? This again, this one here, right? So this is the left triangular ligament. Okay. This is the lesser curvature of the stomach. Attached to it, extending from the lesser curvature to the liver, is the lesser omentum. Okay, so this is the lesser omentum, this is the greater omentum, the gastrophrenic ligament, the gastrosplenic ligament, right? And in this image, this is the stomach, the spleen, the tail of pancreas. This is the left colic flexure. So here again, this is going to be the, yes, it's the gastrosplenic ligament, which has the short gastric vessels. And this is going to be the lenorenal ligament. What does the lenorenal ligament contain? Can you see the vessel here? This is the splenic artery and the splenic vein and the tail of the pancreas. These are the contents of lenorenal ligament. And this one here, very important, yes, extending from the left colic flexure to the diaphragm above, it is the phrenicocholic ligament, right? This ligament, it prevents the downward extension of the spleen in case of splenomegaly. So the spleen, the direction of enlargement is towards the right iliac fossa. Which of the following ligament developed in the aromatic structure? Yes, the one pointed out is the ventral mesentery. Among the options given, right, the falciform ligament, that is derived from the ventral mesentery. So in this question, we have discussed the derivatives of ventral mesogastrium, dorsal mesentery. We have looked into the embryology image as well as gross anatomy image plus the sagittal section, right? And also we have learned the development of spleen. Let us move on to the next question. Which of the following is most common site for intraperitoneal abscess in relation to the liver? So please don't get confused with these terms. It is very easy. Come on, let's do it. The peritoneal cavity as such can be divided into two, isn't it? This is the liver. This is the stomach. This area shown in blue color, the part of the peritoneal cavity that lies behind the stomach, right, and extends beyond the boundaries of the stomach, this is called lesser sac. The lesser sac, it allows expansion of the stomach as a bursa for it. Hence, it is also called omental bursa. Right? And the rest of the peritoneal cavity, yes, we are going to call it as the greater sac. The only communication between the greater sac and the lesser sac is this foramen, which is called as the epiploid foramen or the foramen of Winslow. Its vertebral level corresponds to T12. The boundaries of it is, you can have a look into the session in abdomen on peritoneal cavity, right? Now, this peritoneal cavity is going to be divided by the presence of the transverse colon into a supracholic compartment above the transverse colon and the infracholic compartment below, right? The space on either side of the ascending colon and descending colon, we call it as the paracholic gutter. The supracholic compartment, with the presence of the liver, it is going to be further divided into right and left subphrenic spaces because these spaces are situated below the diaphragm, right? So it's very easy, nothing to get confused, right? So write it right side and left side. And then, yes, first write the extraperitoneal space. The right extraperitoneal space is nothing but the bare area of the liver, and the left extraperitoneal space is nothing but the bare area of the stomach related to the posterior surface of the fundus, right? And then we are going to divide the intraperitoneal space into anterior and posterior. The right anterior intraperitoneal space, it lies to the right of falciform ligament, okay? And that is going to be called as the right suprahepatic space. And the left anterior intraperitoneal space will lie just to the left of the falciform ligament. We will call it as the left suprahepatic space. So the anterior space, we call it as suprahepatic, right? The posterior intraperitoneal space, we call it as the subhepatic. The right posterior intraperitoneal space, we call it as the right subhepatic space. Since this space lies between the liver in front and the right kidney behind, it is also called the hepatorenal pouch of Morrison, right? Whereas the left posterior intraperitoneal space will correspond to the lesser sac or the omental bursa that is situated behind the stomach. Got it? Do you want me to repeat it again? So the supracholic compartment divided into right and left. Write down the extraperitoneal space first. Extraperitoneal space is nothing but just the bare area. So on the right, it's the bare area of the liver. On the left, it's the bare area of the stomach. Done. And then we are moving on to the intraperitoneal space, which can be divided into anterior, posterior. On the right, we call it as the right suprahepatic space, the anterior one, and the right posterior one is the right subhepatic space. On the left, it will be left suprahepatic space, right? and it lies to the left of the falciform ligament related to the left lobe of the liver. And the left posterior intraperitoneal space is nothing but the lesser sac. Easy? Come on. Okay. Now, the right subhepatic space, yes, I told you it's called the hepatorenal pouch or the pouch of Morrison. The right subhepatic, which we also call it as the right posterior intraperitoneal space, isn't it? Right. We are going to discuss it in detail because this is the most dependent part of the peritoneal cavity, especially when the person lies down. Right? So that was our question. The most common site for intraperitoneal abscess in relation to liver is, of course, the right subhepatic space or the Morrison's pouch or the hepatorenal pouch. Okay, the hepatorenal pouch of Morrison, anteriorly it's bound by the inferior surface of liver, and posteriorly what do we get to see? The right kidney, anterior surface of the right kidney, and sometimes the anterior surface of the right suprarenal gland. Above, it is going to be limited by the inferior coronary ligament. We saw just now, right, the picture of it. Yes, it's derived from the ventral mesogastrium. And below, this hepatorenal pouch of Morrison is continuous with the right paracolic gutter. Okay. On the right side, it is going to be limited by the diaphragm. And on the left, through the epiploic foramen, it communicates with the lesser sac. So, as I told you, this is the most dependent part of the pelvic cavity when the patient is in the supine position, and the common site for abscess collection, right? The other names for this right subhepatic space is right posterior intraperitoneal space, hepatorenal space, and the pouch of Morrison, right? Identify the congenital anomaly shown in the newborn baby. This is again a frequent repeat question. So what you see here, below the umbilicus, you can see that the anterior abdominal wall is absent. It is not formed. And what you see here is actually the interior of the bladder. How do you get to see the interior of the bladder? Because the anterior bladder wall is also not formed. Okay. This condition is called ectopia vesicae, where the infra-umbilical part of the anterior abdominal wall is deficient, the anterior bladder wall is not formed. You get to see the interior of the bladder. This is the region of the trigone. You see the mucosa of trigone, right? And the urine dribbles. At the same time, you can see the urethral opening over the dorsal surface. And also the urethral opening is present on the dorsal surface epispadias. So what is the reason for this? What is the embryological basis for ectopia vesicae or exostrophy of bladder? So initially, the embryo is in the form of a bilaminar germ disc, and then the trilaminar germ disc, and then it forms the head fold and tail fold, and finally the lateral folds. The lateral folds, they fuse in the midline. Okay, when the lateral folds don't fuse. So this is the head fold, the tail fold. Failure of fusion of lateral folds. and failure of migration of mesenchyme into the lateral folds, especially in the part of the anterior abdominal wall below the umbilicus, that results in ectopia vesicae. Right? So this condition, it's called bladder exostrophy. The other condition, omphalocele gastrochisis, persistent vitellointestinal duct, has been discussed in detail in your embryology session with nice images. If you want further details, please look into it. Coming to the last question in this session, a very, very important and frequent repeat, urethral injuries, right? A 32-year-old male patient with history of motor vehicle accident presented to casualty with pelvic fractures. This is the important clue, right? His vitals are stable, but he is unable to pass urine. On examination, bled at the penile meatus. A retrograde urethrogram has been performed and shown below. So the contrast in this picture, it's not confined to the urethra, right? It has extravasated because there's rupture of the urethra. What is the most likely site of urethral injury? Just by looking into the picture to diagnose the site of urethral injury might be difficult. But the main clue here is pelvic fracture. Pelvic fracture is always associated with rupture of the membranous urethra, or the other hand, membranous urethral injury is always associated with the overlying pelvic fracture. Come on, let's have a interesting discussion into it. Okay, so can you identify the pubic bone here, right? And this is the sacrum, so this is anterior and this is posterior. This is the urinary bladder. You can see the prostate, right? Let us identify the parts of the male urethra here. Traversing through the prostate, this is going to be the prostatic urethra. And here, passing through the urogenital diaphragm and through the perineal membrane, this is going to be the membranous urethra. Right? And traversing through the, yes, the bulb of the penis and the corpus spongiosum, we have the spongy urethra, which can be further divided into proximal part, the bulbar urethra, traversing the bulb of the penis, and through the corpus spongiosum, the penile urethra. Right? The narrowest part of the male urethra is the external urethral meatus, followed by the membranous urethra. Also, this membranous urethra is the most fixed part of the male urethra. Another way of dividing the male urethra is in relation to this perineal membrane. This is the perineal membrane, right? Proximal to the perineal membrane, we call it as posterior urethra. The part of the male urethra that we see proximal to the perineal membrane. It includes the prostatic urethra and the membranous urethra. This we call it as the posterior urethra. It measures around 3 centimeters. Right? And distal to the perineal membrane, right? We call it as the anterior urethra. It consists of the bulbar urethra, right? And the penile urethra. It measures around 15 centimeters. So the membranous urethra is classified under posterior urethra. Okay? Posterior urethral injuries mainly involves the membranous urethra, right? So this is a membranous urethra. Okay, so any blunt trauma, a road traffic accident resulting in fracture of the pelvic bone. You can see it here, right? It is associated. It can always cause injury to the membranous urethra. 10% of the pelvic fracture associated with urethral injury following RTA, road traffic accident, or blunt trauma. Okay, but all membranous urethral disruptions due to blunt trauma have pelvic fracture. That is why in the case scenario I told you, if you see the word pelvic fracture, it always refers to injury of the membranous urethra. Understood? Okay. So, posterior urethral injury, yes, I told you commonly involves the membranous urethra, right? And it presents with a triad of symptoms: inability to void urine, blood at the urethral meatus, and palpably full bladder is very characteristic of posterior urethral injury. In this case also we saw that it was associated with pelvic fracture. The patient had difficulty in voiding urine and yes, blood at the urethral meatus, right? And anterior urethral injuries, yes, involving the bulbar urethra or the penile urethra, isn't it? Most commonly, they are straddle injuries. Like the images shown here, abducted position of the thigh, you're striding against something that can injure the, yes, bulbar urethra or the penile urethra. Other than that, iatrogenic injuries, catheter related, post surgery, endoscopy, radical prostatectomy, and penetrating injury can also injure the anterior urethra. And in case of anterior urethral injury, right, the penile urethra, if the buccal fascia that covers the penis is going to remain intact, right? If the injury is within the buccal fascia, then there will be hematoma, discoloration involving only the penis, edema, discoloration of the penile shaft as you see here. But if the injury goes beyond the buccal fascia, then there can be swelling, discoloration not only of the penile shaft but also accompanied by enlargement of the scrotum. The extravasated urine can reach even the lower part of the anterior abdominal wall, the superficial perineal pouch. And do you remember what is the anatomical basis behind that? Come on, let us recollect. So, we know that there is no deep fascia in the anterior abdominal wall, right? But a point below the umbilicus, yes, the superficial fascia will split into two layers. Do you remember? A fatty fascia of Camper and a membranous Scarpa's fascia, right? The continuity of Scarpa's fascia is important. So the Scarpa's fascia that you see here, if we trace it down, you can see it becomes continuous with the fascia of the penis and then with the dartos muscle of the scrotum and then with the Colles fascia of the perineum. This is the Colles fascia, right? This Colles fascia, it attaches to the posterior aspect of the perineal membrane. This space is the superficial perineal pouch, isn't it? And this is the external oblique muscle. This space between the external oblique muscle beneath and the overlying Scarpa's fascia is called the superficial inguinal space. I'll repeat that again for you. The Scarpa's fascia is continuous with the fascia of the penis and with the dartos muscle of the scrotum, with the Colles fascia that fuses with the posterior aspect of the perineal membrane, right? And you can see that the space beneath the Scarpa's fascia is going to become continuous with the around the penis, around the scrotum, and with the superficial perineal pouch. So, here, in this case, you see a rupture of the bulbar urethra, right? And the urine from here. And the urine from the urinary bladder, it has passed through the prostatic urethra, the membranous urethra, from the bulbar urethra. Through the rupture here, it has entered the superficial perineal pouch. And then around the scrotum, which causes enlargement of the scrotum, around the penis, and also extending into this superficial inguinal space in the lower part of the anterior abdominal wall, right? So, injury to the penile urethra, all this will happen. Yes, in this case, yeah, a 32-year-old male patient with history of motor vehicle accident has presented to casualty with pelvic fracture. Pelvic fractures, vital stable but unable to pass urine, bled at the penile meatus, right? The urethral injury, the site of urethral injury is membranous urethra. Okay. So, hope this session was useful for you. If you want further details, you can look into the corresponding session in your gross anatomy or embryology, right? Happy learning. Thank you.